Welcome to Mental Health, It's a Trap. We're your hosts, Susan and Stephen, mother and son, unravel the complexities of the mental health traps people fall in. Join us on this podcast journey as we demystify the mental health labyrinth, explore common issues, and provide you with tools to navigate this sometimes extremely daunting terrain. You can expect engaging conversations, personal stories, and probably also have a laugh or two. Access to mental health care should not be what causes you additional stress. We invite you to follow along and we can embrace the darkness together.
All right, welcome back, everybody. Today we have an awesome person with us. We have Luci. I might be a little biased because I've known Luci for a very long time. And as we kind of started off this podcast talking about the death of my sister, Stacy, that is one way that the way that I met Luci, through the Compassionate Friends. And we always like our guests to kind of introduce themselves so that they can share what they want to share. And we will be talking more about grief and loss and her experience in that. And we will just see where the conversation goes. So I am so appreciative to have you on. Luci, would you like to introduce yourselves?
Hi, my name's Luci. I am an RN living in Kansas City, and like Stephen said, I am a bereaved sibling. My oldest brother, Doug, died in a motorcycle accident in 1990 when he was 23 and I was just a baby. I was 9 months old. And then my second brother, Tony, died in 2009 from a heart condition called cardiomyopathy. I was 19 and he was 35. I also have two other surviving siblings, sisters who are twins, who are 29 now, and they were not yet born and 14 when our brothers died.
Well, welcome, Luci.
Thanks. I'm happy to be here. Like Stephen said, we've known each other for a really long time, and I love how somebody at TCF earlier this year said that whenever they think of Stephen, they think of me. Whenever they think of me, they think of Stephen, and we're just two peas in a pod.
So let me share something with you about that, because people used to look at Stacy and Stephen that way. They weren't one without the other. It was always Stacy and Stephen, Stacy and Stephen, and people didn't know them separately than that. So that's interesting.
Yeah, well, and I think what's really funny is I think my little sister Gina is the first Rossi that Stephen met, because I remember her texting me about having lunch with him at one of the conferences and was like, oh yeah, I know him. He does the backflips.
Oh, the infamous backflips at the conferences, yes. Not anymore, though.
That's okay.
Yeah.
Yeah, but also people aren't, I think people are also forgetting too, because they'd be like, oh yeah, he did the backflips. And they'd be like,
Yeah. And so you're an RN, so you have a lot of medical experience.
Yep, I've been a nurse for over 8 years now, and I've been in healthcare 13, 14 years total. So basically my entire adult life.
Yeah. And so before we got on, we were just talking briefly about, whole person wellness in regards to mental health and physical health, and how to kind of pay attention to both, right? And not compartmentalize those areas. And then how grief can play a role and how it manifests physically in people, as
totally.
well as in mental health. So do you have anything you can share about medically what you may have seen over your years of, or even how grief has impacted you and manifested within you.
I definitely know that I will definitely get like some psychosomatic, like physical complaints going on. If I'm working through something like really heavy in therapy, I'll usually end up with like bad back pain that kind of seems to come out of nowhere. And so I've done some more somatic like body work in the last few years to like listen to my physical form, and not just rely on like how I'm feeling mentally, but listen to my physical body, and give myself breaks and healing time. But I remember like going through some heavy stuff in therapy, and then like the next day waking up and like being really achy and not really being able to move a lot, and going to the chiropractor, and he's like, well, what did you do? And I'm like, well, I went to therapy and, had a good cry, and now I need my back adjusted. And he looked at me like I was crazy, but I was convinced that was the link. So then I also try to be a little bit more proactive and like do things to take care of my physical body, like moving my body regularly. I live downtown, so I like walk my dog a lot, and I like to spend time outside to try to like make sure I'm getting sunshine and nourishing my body, and staying hydrated and doing all the things that doctors tell us to do and that I tell patients to do.
Right. And we're usually the worst offenders of it, right? In our professional life, right? We give all of these great recommendations and or advice. Not a big fan of the word advice, though we'll use it for now. And being able to sit, because doctors will say, oh, take a warm bath. Oh, you were in a car accident and your anxiety is off the charts. Just get in the car and drive every day, without really thinking, how have these experiences impact psychologically, and and grief can be incorporated into that because it impacts the whole person. And I think we sometimes compartmentalize things to the point where it's like, just go and do some breathing. But when you tell someone that, they might go home and go, what does breathing mean? What are the real benefits of, how do we help people practice things that they can start to be more mindfully aware of how it's helping them, how it's helping their body, how it's helping their mood, and all of those things. And I think that, I now work in an integrative care model where it's a primary care office and mental health. So I do the mental health component, and I have to educate the providers a lot because, again, that's not what they went to school for. Though they want to bring this into their practices, which is great, though also being aware of, sometimes I get patient referrals and the patients tell me, my doctor's telling me it's my anxiety. And I'm listening to the things that they're telling me, and I go, I'm telling you from a mental health perspective, there's something more going on than anxiety. So we're going to go back to your provider. We're going to advocate effectively, so again, it's teaching them those skills to advocate for themselves and really being able to talk about the symptoms. And I say to patients, write things down. The frequency, the duration, because when you go in to see your provider, people go in, the provider says, well, how long has that been happening? Oh, I don't know, a month, a year, I don't really know. Well, what's the intensity of it? Well, some days it's okay, other days. So, but we're not teaching people to really put into words what they're feeling in their body, right? And it kind of helps us determine, is it psychosomatic? Is it some medical condition that's going on? I had one patient being told it was anxiety with migraines, and when I was talking to the patient, I said, there's something going on. That patient ended up having a malignant brain tumor.
Oh my goodness.
So, that's an extreme case, though again, when we minimize and say, oh, it's just anxiety, let's kind of check them out medically. Let's make sure that there's no underlying medical condition going on. And so really collaborating between the groups, right? To help people, instead of people feel like they're being the pass the buck. Oh, I don't want to deal with this. Let me send you off to mental health, or mental health saying, I don't know, I'm going to send you off. Instead of that, like, how do we work together to really bridge and make the ability to navigate their care more accessible?
Yeah. Well, and I love that you mentioned like self-advocacy, because I think about how I'm health literate. Like, I understand how the system works because I've worked within it for so long, and I'm a well-informed like health consumer, and I know that I hit barriers to care and have trouble getting my needs met, and I think I'm a good advocate. And then I always imagine what it must be like for people who didn't grow up in the system and don't know why insurance requires referrals or what an out-of-pocket max is or anything like that. And I find myself having to do so much education with patients about just like how healthcare as a whole works, whether that be mental health care or physical health care.
Yeah, and that's kind of one of the reason we call the podcast the mental health it's a trap.
Mm-hmm.
And we're not saying it's a trap, though people struggle to navigate it. And I'm a good advocate, and I will push back at any person, any organization, any institution when I know something is not being done to support the people that we serve. Mm-hmm. And I try to teach the clients that I've worked with over the years and the patients now that I'm in a primary care setting about how to speak effectively with their providers and to be able to say, I don't agree with you, and this is what I feel like I need. Let's talk about it, right? Instead of just being shut down or, whatever. It's really tough. And Stephen and I have had podcasts where we talked about finding the right fit.
Mm-hmm. Oh, I've gone through that recently myself. I moved from Colorado a couple years ago to Kansas City to be closer to my little sister, and left a really great psychiatrist behind that I'd worked with for years and had a great rapport with, and took forever to get in to the psychiatry office within the health system where I work. So to get in, I had to wait a year for my referral to go through to get an appointment. And then I just got assigned to a random provider, and like, this is who my health insurance will pay for me to see. And it's like, this person and I do not click at all. I'm literally just looking for chronic med management. Like, I need somebody to prescribe my Vyvanse for me. And she's like digging up the past and like, well, I need all this documentation that, it's not enough that you've been on this medication for years or that like this other doctor wrote the script. Like, I need the original testing documentation that says you have ADHD, and then with like trying to add all these other diagnoses on. And I'm like, for what? Like, I don't agree with you, and I don't think that the objective data supports your theory either. And so like, I'm gonna have to pay more money to go outside the health system to get a different opinion, because it was just like, and I think about like how frustrating that was for me as somebody who's, like I said, well versed in all of this stuff. Like, I'm not a stranger to psychiatry. My mother is a psychiatrist, and I've been in and out of therapy since I was 10. So like, yeah, she was definitely not the right fit. So I'm looking back to the drawing board and looking at finding a better fit so I can continue to get my medication. And hopefully, if I'm in a private pay, won't have to wait another year.
Right, exactly. And and I think this, just for our listeners too, there are some people out there that will do a sliding fee scale and things like that to really help those who may not have insurance or their insurance companies. I'm gonna throw it out there, and they can shoot me later. I don't really care. Have made access to care almost impossible.
Mm-hmm.
We have to follow their referral things. Oh, you have this problem, so we're going to send you to physical therapy. They might do an X-ray before, might send you to physical therapy, and then an MRI or a CT scan after that. My question to the insurance companies is this: there may possibly be an injury that when you send someone to PT, you may be causing further injury to that person because you don't even know what's going on internally in the body that you cannot see. So, listen, I just had back surgery. I've dealt with back pain for, I don't know, 18 years. I've slept in a recliner since 2008, and doctors just kept sending me to PT because that's what my insurance. I'd go to PT, they would cause more pain because it wasn't what I needed. I paid for stuff out of pocket, for chiropractic, traction, you name it. I did that whole thing. It was only alleviating symptoms. It wasn't taking care of the problem. So I elected to have back surgery, and I'm hoping that it works. So far, so good. And again, it's like not listening to the patient. You're not listening to what people are telling you. And I get that providers are kind of, they're kind of strapped to what the rules and regulations are. Though I've said to my providers, why aren't you fighting back to the insurance companies? You are the providers who are credentialed with those insurance companies.
Mm-hmm.
Like, we need to take a stand about having better access to care. And we would have, I don't know, I think if we were more proactive and taught people how to work through trauma more effectively, and how to take care of their bodies without telling people what to do, versus having a conversation to find out what they can do for themselves and slowly work towards goals, right?
Yeah.
And it's really frustrating. So back to the better fit, I remember changing my primary care provider recently, and I'm in the same health system that I've been in for many years. I had a new provider 2 years ago. It was not a good fit for me. I called them, the patient relations or whatever they call it, and I said I would like to request a new provider. And that person said to me, "How many times have you requested a new provider?" I said, "I don't really care how many times I've requested a new provider. I'm paying you, and I will get the doctor that I feel is listening to me, that will work with me, and that won't treat me like a number." We need to be treating people with quality and not quantity, right? And I said, "I'll drive over to your office and talk to anybody you need me to talk to over there, but and thankfully I found a PCP. I met her for the first time and she was great. That's
Good.
not always the case. If I go to the store and buy if I want comfortable shoes and I buy, 10-inch stilettos, I'm going to return them. They're not comfortable. Though we can't do that for our physical and mental health, because then we're known as doctor shopping, med seeking, all of those things. So, girl, you just keep pushing forward, get your needs met in whatever way you need to.
Oh, I will. I already got some names to check out, and I need to do the scary part about calling offices and making appointments. This I hate doing. I talk to people all day long for a living. It's like I don't want to talk to anybody on my day off.
Well, it's for you, and you are important. So put that time aside for you to do that, and not have to worry about meeting with this other provider who is just not working well for you.
I think
Maybe
that's
I'll call after we're done here. I feel inspired.
Even if it's one call a day or one call, 2 calls a week, just set your objective. Sometimes it's easier to make 1 or 2 calls at a time than to sit and make multiple calls. And so what kind of questions would you ask them?
That's a good, I don't know. I know I was actually just having this conversation with some friends last night about what went into picking my local therapist. And I feel like I was able to be more persnickety about what kind of therapist I wanted. And so I got on Psychology Today when I moved here and input my insurance information and where I lived, and that I was looking for, somebody who took my insurance, who did in-person appointments, who was accepting new clients, and then would specifically, when I reached out to them, would ask about experience with LGBTQ clients and trauma and grief and loss, and then say I was an experienced patient, and so I was looking for an experienced provider, and to work on some trauma. And I definitely know that I talked with some people that were not going to be the right fits, because I wanted to do in-person sessions. I didn't want to do exclusively telehealth. I didn't want a religious-based approach. So I feel like I'm good at advocating for myself there. And then, but with psychiatrists, it's so much the luck of the draw that it's just, who can you get in to see? I know when I lived in Colorado, one of my criteria was because my mother was also a psychiatrist, I didn't want to see, there were certain people that she had worked with or that I had worked with when I was a mental health nurse that I didn't want to see. And that kind of narrowed my list down. In fact, it narrowed it down a lot, because as you know, it gets to be a small community after a while.
Yes.
Especially in smaller cities.
Right. So I think that you are so much more ahead of the game than I've ever heard anyone in my years of doing mental health. Of really going, having a good sense of what you're looking for, and those things. Because Stephen and I had talked about so what do you look for in a therapist? What do you look for in a psychiatrist? And unfortunately, people, particularly for psychiatry, people are just I'm going to take whoever I can get because I can't get anyone. And I'm like, oh, no, don't go in with that. Let's really talk about. So when I'm trying to help my patients, when I worked in community mental health, they had to work with our providers within our agency. That was that. In primary care, we don't do psychiatry in the clinics. We have a psychiatry department in the hospital, we're up north in New Hampshire. And they generally don't see patients in the other clinics because we're further away, and and they're really servicing the area where they are. So I often am helping patients find psychiatrists, and I will actually, because a lot of them will say, we'll do a 15-minute consult. So I will call them with the patients. Some of my patients will say, I'll call on my own. Some of my patients say, will you call with me? I'm like, absolutely. And I've had some patients call and say, leave a message. Hi, my name is Susan. I have PTSD. I have trauma. I have anxiety. These are my and they go on and on and on. I go, oh, hell no. That is not the message you want to leave as your first initial message. Your first outreach is going to be, this is my insurance. Do you accept it? Are you accepting new clients? These are the diagnoses that I have. Can you treat those? And what is your rapport like with your clients? Ask them, you can interview them.
Mm-hmm.
Which I think is, now some of them might not be open to that, but listen, when I'm looking for providers and stuff, When Taylor was little and I had to find her a pediatrician, I went around and I set up appointments with all these different pediatricians and had like just a 15-minute, hi, I want to get to know you to see if you might be a good fit for my kid.
I love that.
Mm-hmm. So that could be something you could do. You just make 1 or 2 calls a week and say, can I just do a 15-minute consult on the phone to see if we might be a good fit? Because for them, obviously, they want to work with people they can work with as well. So why go through all these appointments to find out, oh, I can't work with this person?
Mm-hmm.
Okay, you're up, Stephen. You have any questions or comments?
Well, just to help people out as we use psychosomatic, people are like, what the hell is that word? Essentially, it just means the mind-body connection. And as we've talked about before, cognitive behavioral therapy is similar, how our thoughts can impact how we behave. And so psychosomatic is the experiences that we have, that we go through, trauma, grief, car accidents, bad and ugly things, and how they can have or leave an imprint. I'm not sure if there's a better word for that in our bodies. So as we go through things, as we have thought memories, we also have body memories. And so we can forget over time and not necessarily think about the things that we've been through, but there's a felt sensation. So our body remembers it. So a smell, a sound, a date, a time. Those aren't always things that we always think about. And psychosomatic just means when we smell something, that reminds us, when we hear something, when it's a date or time that we don't think of in that moment, our body can react in stress, tension, pain. And like Luci said, going to therapy and having a good ugly cry session activated something in the body that created the back pain, and then going to get it fixed. And someone was like, probably saying like in their heads, you're crazy. That can't happen. Also speaks to how not that they're not a good fit, but not every profession is knowledgeable in trauma-informed care, especially when it comes to grief and loss, because people often, fancy word, pathologize it.
Mm-hmm.
It's like it's something bad. It's an illness. It's not real. It's in your head. A part of it is, right? It's our thoughts, and our thoughts can create how we feel. But again, our bodies have the memory of what we've been through, and it speaks to us in the physical form and not the verbal form. The body's not going to talk directly to us in words. It's going to be either thoughts, images, or probably pain.
Mm-hmm.
When you live with that long enough, you forget about it in a sense that it's just like, oh, I've had that pain all my life, or I don't remember when it happened. When we talk about when you go to a doctor and you have to, well, when was the first time you experienced it? Oh, I don't know. I've lived with it forever, right? And you can't really, and that's a part of the disconnect, is because in being the professional and the doctor, that's helpful for them to know, but they're also not mental health doctors always. So they're not going to go into the past like, oh, let's talk about the traumatic things that happened in your life.
Yeah. Well, I mean, and tie it back with like insurance and just the state of for-profit healthcare nowadays too is that, like, I know as a nurse in the hospital, and I work for a unionized teaching hospital, so I have resources now that I have never had before in my career. So like I'm really lucky. I know that I have a lot of tools in my tool belt, professionally speaking, but there are still days where I don't have time to spend, sitting one-on-one with a patient and really giving that trauma-informed care approach, because I've got other patients, or I'm more concerned about something physical that is more immediately life-threatening or more dangerous, and it's so hard.
And I think a big part of that comes from our culture of quantity over quality. And I think we do a huge disservice to human beings, with that versus, it's kind of like when I think about it, I feel like we keep people sick in order to keep jobs.
Yeah.
On some level.
And that's kind of like the really screwy thing about what I do for a living is that I work with a lot of cancer patients having surgery and having cancer cut out. And so it's like in some ways, like I have job security because there are sick people. And when I worked in the ER, I had job security if there were accidents and sick people and bad things happening. It was
right. So we know that we need these positions because people are going to get sick. Some people are more prone to, terminal illnesses, and those things are going to happen. We know that.
If you are enjoying and connecting with Luci, registered nurse, bereaved sibling, and so much more, stick around for part 2.